For the day. This will be a mixed bag. We have excellent talks lined up for you. We have a recorded talk on the assessment of cardiac dysfunction in liver diseases from Dr. Madhumita Prem Kumar. And we have none other than Dr. Harshad Devarbavi to speak to us on drug-induced liver injury in India. I call the respected chairpersons for the session to kindly grace the stage with their presence. Honorable Aba Nagral ma'am, can you join us on stage? Dr. Mukul Rastogi sir, Dr. Rajesh Gupta sir, Dr. Brij Sharma, I don't think so. Chairpersons, the stage is yours. The first talk is a recorded talk.
Hello, my name is Dr. Madhumita Prem Kumar and I'm here to discuss cardiac dysfunction and cirrhosis. No relevant disclosures for this presentation. In this presentation, we will discuss the following factors: cirrhotic cardiomyopathy, the role of alcohol and the liver, how we assess cardiac function in the intensive care unit, how we look at cardiac function and look at complications of cirrhosis such as HRS-AKI and circulatory failure, and of course the importance of coronary artery disease and cardiac function in terms of liver transplantation. Cirrhotic cardiomyopathy is characterized by left ventricular systolic dysfunction or diastolic dysfunction in the absence of an alternate cardiac pathology. It is associated with the etiology of liver disease in some cases, such as metabolism-associated liver disease or alcohol-related causes, but in most patients it is independent of the underlying liver disease etiology, but associated with the severity of hepatic dysfunction. In the early phases, it is in a compensated state and the patient actually has a hyperdynamic circulation with elevated cardiac output. But gradually, as the liver disease progresses and the systemic inflammation increases, it is associated with a reduction in the cardiac output. Cirrhotic cardiomyopathy is associated with changes in portal hemodynamics, such as increased portal pressure and release of vasodilatory substances. It is also associated with changes in the splanchnic circulation and the systemic circulation, resulting in a hyperdynamic circulation. The activation of the renin-angiotensin-aldosterone system has effects on the kidney and other organ systems. The diagnosis of CCM is based on presence of systolic dysfunction as a reduced ejection fraction or global longitudinal strain, and it utilizes the septal E by E prime ratio of more than 15, the mitral E prime velocity of less than 7, tricuspid jet velocity and left atrial volume index. These criteria have been modified in the 2020 CCM consortium criteria as a modification of the original ASE guidelines of 2016. Supportive criteria such as ECG changes and association of biomarkers are also used. Therefore, in the updated guidelines on decompensated cirrhosis, the new criteria with transmitral Doppler assessment is used, including the assessment of global longitudinal strain. The role of cardiac MRI has gained recent interest. In patients with cirrhotic cardiomyopathy, complications of cirrhosis such as HRS-AKI and development of infections such as SBP are associated with a reduced cardiac index as a manifestation of cirrhotic cardiomyopathy. In addition, detailed cardiac evaluation should be done as part of assessment for TIPS and liver transplantation. Prolonged alcohol consumption of 7 to 15 drinks per day for about 5 years can result in alcohol-related cardiomyopathy. This is due to the presence of oxidative stress, activation of the renin-angiotensin system, which causes increased collagen and fibrosis in the heart, apoptosis, and decreased activity of nitric oxide synthase. This results in cell dropout and a weakly contracting myocytes and leads to progressive left ventricular dilatation, thinning of the wall. So we have a very dilated heart in alcohol-related cardiomyopathy. This progressive LV dilatation leads to further heart failure-related symptoms. There is a controversy regarding the protective role of alcohol in the heart, but the putative effect is due to increased HDL. reduction in CRP, reduction in platelet reactivity. However, this is controversial. What is well known is that alcohol consumption in excess can lead to sudden hypertension, endothelial dysfunction, oxidative stress, and activation of the PAI pathway. So this predisposes to increased thrombosis and sudden cardiac arrest. A daily alcohol consumption of more than 80 grams per day results in inhibition of protein synthesis, oxidative phosphorylation, fatty acid esters, and increased free radical damage, including direct damage to the myocardium. This results in a spectrum of abnormalities related to the heart, such as arrhythmias, hypertension, stroke, sudden cardiac death, and even alcohol withdrawal can be associated with stress-induced cardiomyopathy. In this paper, just the presence of LV diastolic dysfunction was a predictor of poor outcomes in patients with cirrhosis, even if they had normal creatinine to begin with. And over time, patients with higher grades of diastolic dysfunction fared much worse. Please remember, cirrhotic cardiomyopathy is defined by the presence of grade 2 or higher LV diastolic dysfunction, and patients with grade 1 might stage migrate to no diastolic dysfunction with proper therapy. The presence of LV diastolic dysfunction is associated with increased mortality after transplant and even after TIPS. The reversal of the EA ratio is associated with reduced survival after TIPS, and also patients with diastolic dysfunction, the higher grades, tend to have lower survival as compared to grade 1 or no LVDD. Similarly, this data from the Neptune cohort on 114 patients showed that patients with better cardiac contractility, as defined by a global longitudinal score less than minus 16%, perform much better than those with poor cardiac contractility. And follow-up over TIPS, you will see that the cardiac function tends to decline as well due to the increased preload on the heart, but patients who had preserved contractility tended to do much better. Coming to cardiac assessment in the liver intensive care unit. There are several ways of assessing cardiac function in the ICU. The most useful one would be a non-invasive tool, which is the point-of-care ultrasound combined with point-of-care echocardiography. We also have partially invasive monitors, which use both an arterial line and a venous line, such as the PICO setup here, in which there is direct cardiac output measurement by the principle of thermodilution. There are other methods, such as the device shown here, which is a patented device, which actually gives a calculated algorithm-based assessment of the systemic vascular resistance index and the cardiac output. However, these devices are not attuned to patients on high vasopressor support. There is a totally non-invasive tool that is used in pediatric ICUs called the electrical cardiometry, which is based on placement of electrodes on the skin surface and looking at impedance of cardiac signals. This is the least accurate method, and this being the non-invasive tool, using a focus is probably the best method to assess cardiac function in the liver ICU currently. In brief, the point-of-care echocardiography protocol starts from the parasternal long axis view, where we find the left atrium, the mitral valve, moving into the left ventricle, LV outflow tract, and you get a glimpse of the right ventricle as well. We can also look at the LV contractility on the parasternal short axis view. Finally, moving to the apex for the apical four-chamber view, where we can calculate the ejection fraction, the LV OT velocity time integral, the stroke volume, and therefore the cardiac index. We also get a good glimpse of the right heart and the tricuspid jet velocity in this view. Finally, going to the subcostal view, we calculate the IVC dynamics and get an estimation of the right atrial pressure. In the apical four-chamber view, we can calculate the ejection fraction by the Simpson's biplane method. We can also look at the LV outflow tract and calculate the velocity time integral, which can give us the stroke volume and the cardiac output. Therefore, in the assessment of cirrhotic cardiomyopathy, there's a change in the diagnostic definition. Earlier, we used to use the ASE guidelines, but the new CCMC criteria approved in 2020 use these four elements, the septal recordings of the E prime velocity, and also take into account the left atrial volume index. There's a new modality for measurement called spectral tracking, which uses the global longitudinal strain as a measure of systolic function. Therefore, we require more research in this area to see which would be most relevant to us and our patient population. This is our data on the role of CCM in predicting adverse outcomes in ACLF. As we know, circulatory failure is a predictor of outcomes in ACLF. We found that the predictors of requirement of vasopressors were the cardiac index, the mitral wall septal velocity, and the E by E prime ratio. Again, a reduction in cardiac index and an SPRI were associated with an increased mortality. And when we incorporated these cardiac parameters into liver-specific indices such as the MELD sodium and CLIF-C-ACLF, it actually improved the predictive ability of mortality at 90 days. This is our data on the user focus to assess terlipressin response in HRS-AKI. We recruited 140 patients meeting the ICA criteria, aged about 48 years, mainly male, and more than 50% were ethanol-related. Cirrhotic cardiomyopathy is there in up to a fourth of individuals, and LV diastolic dysfunction in up to 45% of individuals. We found that a focus-based observation of a reduction in cardiac index of more than 20% within 72 hours of administration of terlipressin is an independent predictor of non-response. And the cutoffs of prediction of terlipressin non-response included two criteria for diastolic dysfunction and the delta cardiac index, which is a measure of systolic function. Cardiorenal biomarkers, that is combining the use of NT-proBNP and cystatin C, were a good method of determining the patients who will not respond to terlipressin and should be switched to alternate therapies. This data suggests there's a cirrhosis to cardiac to renal axis because of the presence of the activation of RAS and systemic inflammation in the appropriate setting. Cirrhotic cardiomyopathy increases the risk of HRS, and associated reduction in cardiac output can predispose the patient to diuretic resistant or diuretic intractable ascites. It also can predispose to hyponatremia due to failure of the regulatory systems. These can precipitate or decompensate when there are organ failures and result in acute and chronic liver failure. Our modern understanding of cirrhotic cardiomyopathy gives an indication of the cardiac reserve and the safe window for use of beta blockers. As the disease progresses, there's a decline in the cardiac reserve, and when the patient's cardiac index tends to fall, that's when the use of beta blockers will be counterproductive. So as long as the cardiac index is maintained, not the MAP, there's a dissociation between MAP and cardiac index. So as long as the cardiac index is maintained, we can use beta blockers safely, but as disease progresses, the window closes. This data clearly shows the effect of non-selective beta blockers. As long as the cardiac output is maintained, the patient had better survival. With the increase in metabolic syndrome and the association of what was NAFLD and also alcohol-related fatty liver disease, there is accelerated atherosclerosis, especially in an inflammatory milieu where there is gut dysbiosis. It can precipitate heart failure and can also increase risk for cardiovascular and cerebrovascular mortality. Therefore, there is a high risk in these patients. There is a high risk of atrial fibrillation, which increases with liver disease severity as seen by the MELD score. Therefore, it is essential to diagnose these patients for CAD at the time of transplantation, regardless of the cause, and the probability of occurrence of a sudden cardiac event increases, and lower survival is noted in those with coronary artery disease. In patients who have cirrhotic cardiomyopathy related high output cardiac failure, liver transplant may actually normalize the cardiac output. In one study, the cardiac index decreased by a mean of 35% after transplant, but it may persist for longer in patients with alcohol-related disease and those with more severe cardiac dysfunction. Therefore, a multidisciplinary cardiac care is required for liver transplant. The biomarkers for CCM would therefore include those for renal dysfunction such as NGAL, neurohormonal activation such as aldosterone, angiotensin. We can look for inflammatory markers as well as those for oxidative stress or CKMB or troponin I, which would be released due to cardiac myocyte damage. Due to the risk of sudden death, we need to be looking at the exact cardiac structure, especially in peritransplant individuals. There's interest in cardiac MRI, where late gadolinium enhancement and increase in extracellular volume are indicators of fibrosis, and one can also look for the likelihood of reversal of cardiomyopathy after transplant. To summarize, cirrhotic cardiomyopathy, as defined by systolic, diastolic, or electrophysiologic dysfunction, is associated with risk of HRS AKI, poor survival following critical illness, tips associated with risk of PID, and poor survival following transplantation. Coronary artery disease in the peri-transplant period may be associated with sudden cardiac death and post-transplant mortality. Thanks for your patient listening. Last but not the least, I would like to thank the entire team for their help and support.
Thank you, Madhumita, for your excellent presentations. Are you there, Madhumita? Can you listen? Can you hear me? Oh, sorry, recorded. Oh. So, Harshad, the stage is yours.
On drug-induced liver injury, and my special thanks to many of the chairperson, Dr. Rastogi, Abba, as well as Rajesh for being here, and all of you delegates and friends. This is the last day and the last session, and I really admire your tenacity and patience to be here on this last day and the last talks. Thank you very much for being here. So my talk today is on drug-induced liver injury in India specifically and management issues. So there are about 6 large registries of drug-induced liver injury, and I've listed them here, starting from United States, Germany, and India. We had one of the largest series, and some of you have contributed to the Indian series. Most of them were prospective. You'll notice Indians perhaps are much younger with regard to the age of distribution of drug-induced liver injury. For some unknown reasons, women tend to develop more drug-induced liver injury. This is the entire series where we find women less in India. But if you look at ATT-induced hepatitis, women perhaps have more risk of developing liver injury. Particularly in India, the overall fatality, when you look at all the other registries, is much higher, 17%, sometimes reaching 20%. And that's because this is predominantly caused by antituberculous drug-induced liver injury, which is a deadly disease. And the top 3 implicated drugs, if you look everywhere, the topmost drug anywhere in the world is actually antibiotics. And why antibiotics? Antibiotics are given in much large doses. They produce more reactive metabolites, and that's how it produces liver injury. In the United States, herbal and dietary supplements, the second commonest cause. Even in India, herbal and dietary supplements or complementary medicines, the second commonest cause, followed by anti-epileptic drugs. So 3 top causes in India: anti-TB drugs, complementary medicines or Ayurvedic medicines, and then anti-epileptic drugs. Now, coming to the top 5 causes, I listed 2 large populations, India, China, as well as USA. And you'll find that amongst antibiotics, India, it's anti-TB drugs. Overwhelmingly, almost 50% of all causes of DILIs are due to anti-TB drugs, followed by complementary medicines. And we still have a large percentage, almost around 10% with anti-epileptic drugs. And that's because the anti-epileptic drugs that we use are the older generation anti-epileptic drugs, which are much easily available, much cheaper, and have a much wider experience. So phenytoin, sodium, carbamazepine, and as well as phenobarbital. Anti-antimicrobials, which are non-antituberculous, are much less, and non-steroidal anti-inflammatory drugs constitute only 2.8% of patients. Now, again, I listed, to be fair, to also listed some Asian countries, and you'll find again Asian countries, except for China, where complementary medicines are the top commonest cause. Again, the overwhelming majority of DILIs are due to antibacterials or antimicrobials. Now, since anti-TB drugs are the commonest cause, I'll talk a little bit more on anti-TB hepatotoxicity. And why anti-TB hepatotoxicity? Indians are the champions, not just in cricket and kabaddi, but also in tuberculosis. And you'll find that almost 27% of all patients of TB, both the incidence as well as the prevalence, unfortunately occurs in India. And again, a larger number of men develop TB rather than women, but larger number of women die of TB, anti-TB drugs rather than men. So India, 26%, and a large number of patients are from Asia. Now, anti-TB drugs, the incidence, of course, varies anywhere depending on what definition to use. So it varies anywhere from about 5 to 10%. And these are well-controlled studies, so that's why I listed these 6 to 7%.
But whereas if you use both older studies as well as the recent studies, you'll find it anywhere varies from 10 to 20%. But if you look at recent studies, again, anywhere from 5 to 8% of patients also in India. Now, anti-TB drug is the commonest cause of delay. It's the commonest cause of drug-induced acute liver failure. It's the second commonest cause of drug-induced acute and chronic liver failure from the Asia-Pacific studies. When does anti-TB drugs occur? Please bear in mind that anti-TB drug-induced hepatotoxicity can occur throughout the exposure of anti-TB drugs. For example, some patients with orthopedic or bone-associated TB can sometimes develop it at the end of 12 months or even at the end of 18 months. But overall, it occurs in the first 2 months of therapy. And what is the median age? Both our studies as well as Western as well as Eastern studies, anywhere from the median is 23 to 28. So first month of therapy, please be careful and keep them under increased surveillance because that's when most of the anti-TB drugs occur. You know, most people have this, they use any raised AST and ALT elevation whilst the patient is on anti-TB drugs as a default diagnosis of DILI, but this is incorrect, particularly in our country, and a very good study from All India Institute of Medical Science, and I like this study very much. 14 or 15% of hepatotoxicity actually were due to viral hepatitis, and most of the viral hepatitis was actually caused by hepatitis E followed by hepatitis A. So always, at least when you have raised AST-ALT in patients who have anti-TB drug hepatotoxicity, please do at least 2 tests, and that's hepatitis E virus as well as hepatitis A virus. Rule that out. So as I said, the most common of, it used to always break my heart when we used to ask questions in both DM as well as MD, which is the commonest cause of drug-induced acute liver failure. Everybody would say paracetamol. For God's sake, paracetamol is the least common cause of drug-induced liver injury in this country, less than 1%. So, and I'm very happy to say that most students now actually answer that anti-TB drug is the most common cause of drug-induced ALF. In All India Institute of Science study, 5% of all ALFs or more than 1,500 patients due to anti-TB drugs. 22% comes from our series from St. John's, where 22% of all acute liver failures were due to anti-TB drugs followed by anti-epileptic drugs. Mortality you find, again, most drug-induced liver injury, you don't see this high mortality, but some of the unknown reasons, mortality due to anti-TB drugs approaches 3/4, and there are a few reasons why it occurs. Now, these 2 studies we had published on drug-induced acute liver failure, both are single center as well as the Indian network. Again, you'll find anti-TB drugs overwhelmingly. 50% due to any delay, but if you look at drug-induced acute liver failure, it varies anywhere from 63, 2/3 to about 3/4. And again, mortality, unfortunately, is about 66 to 70%. Now, switching to traditional and complementary medicine, as I said, it's the second commonest cause of drug-induced liver injury, both in India as well as in USA, and the first commonest cause of drug-induced liver injury in China. And I have listed the proportion of patients due to traditional and complementary medicines. Now, what are the top herbal drugs that cause? There are so many drugs, and very difficult to identify one amongst the many ingredients that want to develop drug-induced liver injury. And I've listed these both with Taiwan, China, India, South America, and Asia. And you'll find that the 4 commonest ones are 1, Tinofolia cordifolia in India. The largest number of reported series are due to from India, and ABBA was actually the person responsible for triggering reporting the first case series which triggered a lot of case reports as well as series. In China, it's Polygonum multiforum. To Sanchi, that causes hepatic sinusoidal obstruction. And I find that the second commonest cause, and I thought yesterday I saw one patient reported somewhere, ashwagandha, it's again being used extensively in this country, being the second commonest cause of drug-induced liver injury due to complementary medicine. Now, the problem with complementary medicine is, and as you see, this patient who take these, it's several liquids, several powders taken sequentially, tablets, capsules, and concoctions. And in this patient who took it, there are 56 ingredients, and I actually listed all these 56 ingredients. And which amongst these ingredients are responsible for drug-induced liver injury? And I think the ones that are listed, that are colored in red, are the ones that have been most commonly reported to cause drug-induced liver injury. And so you perhaps have to take this as the most common cause or ingredient that produces drug-induced liver injury. And again, just for your information, we used to use turmeric quite a lot in this country. And you'll find that it really has prohibited all health claims and issues regarding turmeric. So turmeric in large doses actually causes drug-induced liver injury. So how do you manage in the last section of my talk, prompt recognition, when you really have to ask them questions, again sometimes several doctors or a period of time, whether they take any medicines or complementary medicines. Consider the differential diagnosis of DILI in all causes of drug-induced liver injury, all presentations of liver injury, as we didn't list it, but it can present as any form of liver injury. Now, even though you identify the culprit and you stop the drug, it takes some time for the liver to regenerate. So just be patient before you find that response to treatment. And unfortunately, there are only few antidotes to drug-induced liver injury. And what are the antidotes? N-acetylcysteine for paracetamol as well as acute liver failure from drug-induced liver injury. L-carnitine for valproate-induced liver injury. Cholestyramines, again, specifically, if you don't think about cholestyramine and if you don't give it, they have a high mortality for leflunomide-induced DILI. And again, those patients who have hypersensitivity, both in the form of drug eosinophilia, systemic symptoms, as well as eosinophils on liver biopsies, please think in terms of hypersensitivity reaction and give them steroids. And again, as Abba pointed out in several series after that with regard to Tinospora cordifolia, this produces a certain peculiar characteristic of what is called as a drug signature, and this is autoimmune-like hepatitis. They need to receive steroids. UDCA can give for those patients with cholestasis, and actually 1 or 2 studies of steroids as well as UDCA for cholestasis. Now, since I knew there would be some hardcore enthusiasts staying here till the very end, I just wanted to leave you all with at least 3 or 4 slides of recent advances. And these are the treatment used for DILI, and these are basically come from China, and you'll see most of the references there. Combination of glycyrrhizine and silymarin, bicyclone, and again Hugon tablets. Some of them are tablets, some of them are intravenous injections, but again, if you have the references there, they have been used, but again, predominantly for herbal drug-induced liver injury rather than non-herbal, and most of them come from China. Now, we know from this gastroenterology study from William Lee, the intravenous N-acetylcysteine improves transplantary survival in non-paracetamol drug-induced liver injury. And he went on to show that those patients who have early encephalopathy, grade 1, grade 2, are actually the ones who have a better prognosis. I talked about leflunomide-induced liver injury, and that's because even if you stop leflunomide, look at that. The active metabolite H771726 stays in the circulation for 2 years. Can you think about any other drug that stays in the circulation for 2 years? And you see this leflunomide being prescribed left and right by orthopedicians. Some of them rarely present with liver injury. So even if you stop the drug, you need to give them oral cholecystiramine 8 grams 3 times a day for at least 11 days. And we actually give them for 14 days just to be sure. And again, in those who take leflunomide, the recommendations are that if you have an AST and ALT more than 3 to 4 times, please stop the drug. Now again, I talked about this old study with regard to valproate-induced liver injury. It really improved outcome. And steroids and ulcerative colitis can severe drug-induced liver injury from Germany. But every time I talk about this, there's always a question about anti-TB drug-induced liver injury. How do you monitor and treat them? So so do we require baseline for patients, LFT for those patients who have TB? The answer is yes. Do we like baseline viral markers? At least we said from the Asia-Pacific recommendation, hepatitis B, C, as well as HIV. But do we monitor the LFT if the baseline is normal? The answer is no. LFT costs money, about 1,000 rupees. Monitoring if LFT baseline is abnormal, of course, we have to monitor them. And those who have liver disease, you monitor them more frequently. Then what about management of these patients? Now, we need to stop the drug if there is clinical or symptomatic hepatitis. And when do we start the drug? Once the bilirubin is less than 1.5 and the AST, ALT less than 2 times normal. And how do we start? There are various modalities you can start. We generally, at least this recommendation is that we start sequentially and stagger the dose. Start with 35% small dose, go to a full dose, and then INH followed by pyrazinamide. But those who have had severe liver injury, please try and avoid 5-pyrazinamide. And what about recommendation? It depends. You need, because they've had one episode of drug-induced liver injury, and most DILIs due to anti-TB are severe, you need to monitor them frequently once you start. Now, last 3 slides, N-acetylcysteine has been used in the treatment as well as prevention of liver anti-TB drug-induced liver injury. This is a fantastic study from from South Africa, a randomized controlled trial of N-acetylcysteine in the management of anti-TB drug-induced liver injury. And what this showed is the time to AST and ALT less than 10 times, although there is no difference with whether you gave them N-acetylcysteine or placebo in the left-hand side, but actually it helped shorten the time of discharge from 7 days with N-acetylcysteine and 18 days with regard to placebo. And what about efficacy of N-acetylcysteine, the prevention of delay? This is a good study that was presented just a few months ago, a couple of months in INASL. Overall, 82 patients. As you can see, controls as well as, you'll find controls as well as non-N-acetylcysteine. You find that when you give N-acetylcysteine and the dose is 600 milligram twice a day, you notice that the prevalence of hepatitis decreased at 2 weeks, 2 months, as well as 6 months. But more importantly, the prevalence of hepatitis at 2 months among patients with slow acetylase status was significantly less, 0% to about 50%. And I bring this up about slow acetylase status because at least 70% of Indians, and particularly South Indians, are slow acetylators. So again, in those who develop ATT DILI, please, I would think, based on this as well as some earlier studies, 600 milligram twice a day of N-acetylcysteine is recommended. So in conclusion, anti-TB is the most commonest cause, followed by HDS. ATT is a deadly drug, causes the most common cause of acute liver failure, ALF as well as ACLF, second commonest cause, prompt identification and stoppage of the culprit drug. There are few antidotes available with regard to drug-induced liver injury, and I think across the spectrum, N-acetylcysteine for non-paracetamol toxicity is again a good drug. Thank you.
Great talk, Harshad, as usual. And I think Harshad has been credited for doing some very pioneering work and putting India and Delhi on the world map. Thanks for that. I had a question. You mentioned the top 3 drugs in India. I just want to know, do you feel that antimicrobials, we do see antimicrobial related DILI very often, but it did not come in your first 3 because it's mild and often does not get reported. So do you think that could be the case?
I think it's quite common. Most Indians, when we look at, compare it to the West, most Indians use antimicrobials for a short period of time. You see, and I always thought that was a good thing, that whereas if you have lived abroad and you see, they give antibiotics for a long period of time. You have a child who has upper respiratory tract infection, they tend to give it 2 weeks, 3 weeks. But in India, it's generally about short period of time. And most of them produce AST, ALT elevation, and by the time it really gets detected, you have stopped the drug. So I think that's how that's why it gets reported less. And imagine most of this reporting that we did, or registry were inpatients. These were from large centers. So we really miss them when private practitioners see these patients.
Harshad, regarding this CAM thing, so thanks to Dr. Abha, which brought this Giloy thing in the public domain and reported first series from India. So what about the conventional drugs, which are the barks, especially alkaloids, which used to contain? So don't fall into the category of these days, or they don't cause a DILI these days anymore? Or have you reported? Because these, as you rightly pointed out, the ingredients are not very, very clear what they are consuming. But the certain concoction which are very still popular in our rural population. So have they fallen out, or the incidence of these kind of liver injuries decreasing?
Yeah, I think the biggest problem is that we all see these patients in our experience, but they don't get reported. And a few years ago, less than 10 years ago, when if you looked at the data, there was hardly any data on complementary medicines producing liver injury in India. It actually were published in Western literature, and we had to identify them. Thanks to Abha's efforts, and I should here really bring it and acknowledge that it is basically Cyriac Phillips from Cochin who has done a pioneering work, who has published a lot of these patients and has brought to light the different ingredients that can produce drug-induced liver injury. So I think to a question, the answer, it does produce. It doesn't get reported. We all see it, and it's very difficult to prove which ingredient. And you see, after Abba's publication, and every time you publish anything on complementary medicine-induced liver injury, you are hounded, to use the word, by both as well in press as well as in elsewhere. So one has to be a little careful and work this up with these patients fully, including liver biopsy if possible, and try and investigate what are the ingredients, because without that you throw yourself to a lot of criticism.
Yeah, so I think what really helped was the COVID pandemic, when people, when it was being promoted, Tinospora was being promoted as a immune booster drug, and everybody was taking it, and therefore we got the numbers. And the patients which we reported were taking pure Giloy. There was no other ingredient. So therefore it was much easier to prove. But when you have a drug, which most Ayurvedic drugs have like 50 ingredients, you don't know what to implicate. So that was the thing which we could do.
Yes, please.
I just encountered a PEG asparginase induced severe steatohepatitis, so it's a documented thing. And what they mention is an IV carnitine as a treatment. Now, do we have any experience of IV carnitine being used?
Yeah, I think I didn't mention, but IV carnitine is also for asparaginase, and I think we give it as whenever we get a few references of asparaginase-induced liver injury. We ask them. These are basically, these are case reports. These are not large series, but since L-carnitine is a safe drug, since it's easily available and it's also quite cheap, we tend to give L-carnitine in patients who develop
as an injectable form.
As an injectable form, yes.
Okay. So I was able to give it as oral tablets only, but yeah, I was not skeptical about giving IV, which I have not used. So thought.
But you can give oral as well.
Yeah, I think it is used by pediatrics a lot in fatty acid oxidation, mitochondrial. So they use a fair amount of IV.
That is because I have no experience of IV carnitine. I thought if anybody has used it.
It's been used. We have used it.
I think, what about the homeopathic drugs? I think Dr. Abi constantly reports about different homeopathic drugs causing severe liver injury even after death. What is your experience?
Yeah,
because homeopathic drugs has been used by millions of people in this country. And we do not know how they work, nothing.
Thank you for raising this question. Two important things. One, it is again credit to Abby Phillips, who reported the first small series of homeopathy drug-induced liver injury, and he's listed several times. Yesterday I was reviewing. Yesterday I was a judge for the posters, and the first person who presented it was a person who had a case where there's severe cholestasis with itching. And then it turns out this patient was again taking a homeopathic drug, Thyrox and syrup, Euroflex or what, Eurotrex. So I think it is, even though they say, as Abby points it out in his publication, even though they say they use minuscule amount of drugs, but it contains a lot of ingredients which are not listed, and it contains many of the listed drugs which doesn't actually contain. And again, it's spiked with many of the drugs, like including steroids. And and plus metals. So it is common with homeopathy medicine.
Sometimes they also use very concentrated from like mother tinctures and other things. So we know that basically all homeopathic drugs in large amount, they are human poisons, arsenic, other things. They are giving in extremely diluted form. They say it works, but doesn't work. I have few experience, patient taking homeopathic drugs coming with acute hepatitis. I don't know, we cannot prove, there's no point in proving it, but those people are not taking any other drug. So there is a point, I think these homeopathic drugs can cause
it can, and I think that publication by Abby Phillips is quite remarkable.
Okay, thank you.
Yeah, nice presentation.
Thank you.
Congratulations. So you mentioned one slide that some Chinese paper where you mentioned some herbal medicines like silymarin or some other drugs. Is there any study from India which is helpful in Delhi, or what is your experience and what are your recommendations?
Now, India, I do not know, but for example, randomized controlled trial was done about silymarin, not for Delhi, but it was used the silymarin and silymarin milk thistle in the US for hepatitis C, and clearly they have shown that silymarin or silymarin group of drugs does not help in resolving hepatitis, at least due to hepatitis C. I'm not sure about...
most of the general physicians, they are using in and out, silymarin and all.
Yeah, but I think if you extrapolate the data that they have done from hepatitis C, it doesn't really help with regard to normalization of liver tests.
Interestingly, the only randomized trial for LIV52 has come from UK, from Royal Free, where they used in alcohol-related liver disease, and they found actually that that group did worse than the placebo. So that's the only randomized trial for LIV52, which is so widely used.
And that was again published only as an abstract. It never went
Yeah.
out for full publication.
I think thank you, Harshad, for nice and presentation, and thank all the participants who have stayed so long at the time of lunch. Thank you, organizer, for giving us this opportunity to participate in the wonderful.
Thank you.
session.
And thank you for
very
all of
much.
us staying, and have a safe flight home.
Wow, what a talk to end the academic fiesta here at INASL 2023. We have had 4 days of hardcore learning inside the halls and fun and frolic outside. I thank you all for attending. I now invite you all to the first floor auditorium where the valedictory function will be taking place for INASL 2023. Thank you all. Join us.